Hello and welcome to the special edition of Catholic Focus. I'm Deacon Pedro. We're doing a series on end-of-life issues here in Edmonton, Alberta. And today, our two guests are two people for whom the issue of pain management is very personal. Lisa Daniels, welcome, and Dr. Robert Hauptman. Now, Lisa, you suffer from chronic pain.
I do.
And Dr. Robert, you're her doctor, but maybe we should start with a little bit of your story, Lisa. How did this pain issue begin for you?
I actually had lost a great deal of weight, and it was after that I developed back pain, quite debilitating back pain, and
But it just sort of started.
it just started, yeah.
Do we know what caused it?
Well, that's the thing. A lot of time these types of things can just develop somewhat out of the blue and a bit insidiously, so it just gradually comes on in patients. Almost always there is some sort of event, so, potentially massive weight loss around stress, sometimes accidents, trauma, and all these things can lead to a chronic pain problem. In Lisa's case, I think it really just kind of gradually gotten worse and worse and worse.
Okay, so it began with back pain. You presumably went to the doctor, and then what happened?
And then I started to get treated for back pain. I started to have injections of cortisone.
Okay, so, and sorry to interrupt, but when you say pain, and maybe, because I suppose there's different thresholds. I mean, I have back pain too, but I don't need injections. So was this debilitating? When you talk about pain, like you can walk, you can stand up, you can function?
It was hard to get out of bed some mornings, and mornings are the worst because I was all stiff.
Right.
And it just seemed to get worse throughout the day.
Right.
And
these injections would be what sort of medication?
There's many things you can actually inject, but in Lisa's case, they were corticosteroids that were being injected to try and disrupt some of the pain pathways, so to give her some relief where we felt her pain was coming from.
And you'd be able to administer those injections at home, or you'd have to go?
No, it's done through diagnostic imaging.
Okay. And then, I'm assuming that it didn't get better.
It helps. It only lasts about 3 months, and then you have to keep doing it.
Okay.
And to be fair, just to kind of maybe intervene with this, I think Lisa, as you go through her story, it's been such a long journey. Usually with people like Lisa, they start off with something that's a bit more acute as an event, and rather than get better, like going back to your point that, you get back pain. Well, we know 80% of the population gets back pain at some point.
Yes.
And, like most of the population, Lisa went through standard therapies. You see a physio, you do exercise, you get anti-inflammatories. But rather than getting better, as most people do, she went on to have daily debilitating back pain. And that's when we started to look at expanding her treatment options at that point, because it wasn't going away. In fact, what we now know with chronic pain patients is they often rewire the pain system. It becomes hypersensitized. So now you have an ongoing continual input from her lower back that isn't improving over time.
Okay.
And to be clear, sorry for interrupting this for a second, but we call somebody who has a pain disorder, we say they have chronic pain when they have pain that lasts longer than 6 months.
Right.
So most people will resolve in that period of time. Unfortunately, in Lisa's case, it didn't resolve.
Right. So then, at some point, were you diagnosed with any particular condition, or is this just kind of like chronic pain that we don't know what it is?
I was told I have arthritis in my SI joints, which is part of lower back, and fibromyalgia.
Yeah.
Fibromyalgia, okay.
As a secondary diagnosis.
Right,
Yeah.
and so that causes pain. Presumably.
Generalized pain as well.
Does it cause any loss in mobility or anything else, or are you?
I try and stay active.
Yes.
It's difficult sometimes. Sometimes it helps, like I find yoga helps because it's the stretching.
Now, and so you said that there was no one event, or has there been an event since that original back pain that kind of made it worse?
I actually was in a car accident this past June. My car flipped 3 times, and I was pinned in the car on the side. And so my whole left side was kind of hurt.
Right.
I had some cracked ribs, concussion, rotator cuff injury, and my arm was really bruised. And then about a month or 6 weeks after, I woke up and I had lost feeling kind of in my arm, and my wrist just kind of hung. And
So you'd lost use of your left arm.
right.
Yeah.
And it was determined that I have radial nerve palsy.
Okay, which is why I see you're wearing a
Yep.
brace. Right, do you have you recovered any of the motion?
I have
or
a bit
use?
more feeling in my fingers,
Yeah,
but nothing from kind of my elbow to my wrist.
right. Now, would you consider, and I suppose you can jump in here, would you consider to be someone with a disability because of your condition?
I don't really consider myself to have a disability.
Yeah.
I have some health issues, but I find if I think of myself as having a disability, it's not a very good mindset for me.
No.
I think that's a valid point. I mean, chronic pain is not a choice, and I just want to kind of step back a bit just to just talk slightly about chronic pain so you kind of understand
Yes.
the breadth of this. That's 20% of the global population has chronic pain. And we understand that to be changes in the nervous system when people develop chronic pain. It starts with an injury, and rather than the system turning off when the injury heals, they continue to generate pain because of changes in the nervous system. So it's always a cause, okay? But we call that now a chronic pain disorder, secondary to back pain, secondary to fibromyalgia, but
Yes.
secondary to a work-related injury, but it's still chronic pain. And that affects about 20% of the population, like I said, so 1 in 5 people, very, very common. But again, going back to the point I was going to make, chronic pain itself, not a choice. How you live with chronic pain
Is, of course.
is a choice.
course.
And I think this is the point Lisa makes, and I think it's a fundamental point.
Yes.
The attitudes we take around chronic
course.
pain can affect how we experience that pain.
For sure.
And you will always have some pain from that rewiring, that chronic signal that's being generated. Even now I can tell you that if we ask Lisa, is she in pain, she will tell us she's in pain. But the intensity of that
Right.
pain can so much be modified by our emotions,
mindset.
by our stress. We talked about this somewhat earlier off air, you and I, by our spirituality,
Yes. Yeah.
and how we approach that as well.
Yeah. So right now, I was going to ask you, well, right now, how much pain are you in? But how are you? So right now, how are you managing? There's medication. There's obviously, you mentioned yoga.
Right.
There's your choices that you're making every morning when you get out of bed.
That's right. I, every morning, choose to be happy.
Yeah.
I choose to look at the small things in life, and it improves my mood a great deal when I choose to do that.
Yes. Were there times, I guess, where that was hard and you
Yes.
were, depressed?
Yes, and I'm not going to lie, it happens sometimes still. Earlier on, it was very hard to get out of bed. My daughter's disabled, so I was limited in the transferring I could do and her personal care, and so that was difficult for me.
Yeah.
But I've kind of worked through that and been better for it.
Yeah. Is the work that is not, I don't even know what to call it, but I was going to say that is not physical, that is not medicated, is that also through the help of your doctor? Like, are you helping your patients with dealing with that emotional, spiritual, social pain?
Yeah,
Or are you just giving her
Lisa do
drugs?
that, right? Answer that question. I mean, she knows how I feel about this, and I can talk to my approach to it. But I suppose from a personal experience, Lisa.
I, like I mentioned in my speech on Tuesday night, when I started seeing Dr. Hauptman, he let me know that I would always have some form of pain. I couldn't just take a pill and get rid of all of my pain. I needed to focus on other things as like secondary to medication to kind of control the pain.
Yeah.
So whether it be, you know, taking a long hot bath or meditating or taking my dogs for a walk.
Yes.
Just anything to improve my quality of life.
In a sense, the health of the brain. So, you know, when I look at chronic pain, I see that there's two main forms of therapy we use. One are the medications, which fundamentally turn the volume down of this sensitized nervous system. But then there's these other forms of modalities that help to actually heal the brain a bit, to make the brain function healthier. Like Lisa was talking about, meditation, prayer, exercise, proper nutrition, choosing to live, choosing to engage in your community again. These are all so important in helping people with chronic pain move forward with their lives and successfully treat it too. It really does successfully treat the condition.
Can you manage all pain, or can it get to the point where there's nothing you can do?
You know, I've been doing chronic pain now for 20 years, 10 years in a specialty practice. I have found very few people, very, very few people that we can't help to some extent. The more buy-in we have with the patients, the more successful our management. But to be fair, that's the same of virtually any other disease we deal with. If you get a diabetic who has no buy-in in terms of diet and exercise and taking care of themselves, I can give them all the insulin I want and we're not going to be optimally managed.
Right.
So the more buy-in I get from patients, we can help them. So, you know, are there unusual circumstances where people are left to live with unremitting pain? You know, I suppose it's always possible, but I haven't seen a lot of that. You know, I've seen a lot of patients come into my office who are not doing well, who are basically bound to their homes, stay in bed most days. They say that their pain levels are 9 out of 10, 10 out of 10, 20 out of 10, and after 6 to 12 months, they're functioning again. They're managing better. They don't have zero pain, but they have reduced pain and they have a better quality of life.
What's the cost like? I guess, I don't know if it's covered by healthcare, how much money you're spending on yoga,
So she
on
pays me under the
meditation.
table every time she sees me.
But I mean,
extra.
can it get to the point where it's...
It can, like for example, Botox is very helpful in my back. However, it's not covered under any health plans. So it's very
cosmetic.
costly.
It's considered cosmetic? Like what?
Well, it doesn't have an official indication, and unfortunately, when it comes to coverage of medications, it's often decisions made by insurers who unfortunately sometimes look at the bottom line rather than what we're doing in practice. So some insurers artificially say if there is no official indication, despite the fact that many of us in the pain world would use a medication for whatever condition, like Botox for some of her pain. They'll say because it's not officially indicated by Health Canada, we won't cover it, which is a shame because it is an effective therapy. Many of the drugs, the pharmaceutical agents that are kind of advancements in the pain area are also not covered. Now, thankfully, some of the ones that Lisa is on right now, most of them are covered.
Most of them are covered.
But there are many other agents that we use that still don't have coverage, so that does put some burden onto the patient.
Yeah. Does it place a burden on the medical system? Do you see any costs to I guess the province, I guess, in terms of dealing with people? I mean, I don't know. I think it's fair to single out people that suffer from chronic pain as opposed to any other disease.
Well, if you look at any disease, there's always direct and indirect costs. And to be honest, direct costs for chronic pain are not huge. But if you take direct plus indirect costs, the cost to the Canadian healthcare system is over $50 billion, which is actually higher than cancer, heart disease, and diabetes combined. So the total economic cost to chronic pain is more than cancer, heart disease, and diabetes combined.
Because of the indirect costs. So
the indirect loss of productivity, family members sometimes have to help out. So a lot of the costs are more indirect than direct. There are some direct costs like medications and injections-based therapies. if they choose one of the better forms of treatment for chronic pain is psychological services. We use a lot of cognitive therapies, and psychological services are not covered, so there's a personal cost to the patient as well. But the lion's share of that is indirect costs.
Yeah. Now you're, I think, fairly young. You have a young family. You have a husband, a daughter. And not to say that would it make a difference if she was older or closer to, I don't know. I don't even know what. Are you able to work? Do you work?
I did work up until my car accident in June, and I'm still off work right now.
Okay, but you could work? Like,
Yeah.
that's still an option for you?
Yeah, I was working part-time
Yeah.
before the car accident.
Yeah. How important is it for patients that suffer chronic pain to actually be engaged and doing?
I say to everyone with chronic pain, you have a job, and that job is taking, full care of yourself.
Yeah.
And full care of your family and engaging in society. And if you do all that, and you have some left over that you can contribute to a job, fabulous. Because we do have data that people who actually work have a better quality of life, have better socialization. There's some real positive aspects to working. They actually usually do better financially. That being said, a lot of people with chronic pain, it's a job to take care of themselves and to look after themselves. And they really don't have a lot left over to do productive, competitive, consistent employment.
Of course, we're talking about end of life issues, and I don't see this as an end of life issue. You're living, I think, fairly well. I don't know, with a condition and with help and support. But there's a reality that options in Canada are changing. One of the, and you can correct me if I'm wrong, but one of the wording that's used is irremediable suffering. Is your suffering irremediable? I mean, your pain, right now I don't know, can it get to the point where, is it going to get better? Does that mean that it's irremediable?
Well, and I can jump in, if you want. From my point of view, irremediable suffering would be persistent, constant suffering, and then you could make that argument that a person with chronic pain we don't, in 21st century medicine, we are not curing people with pain. No. They are still going to be left with suffering, and quite frankly, some days they're going to be left, there are days, I'm sure Lisa can attest to this, where the pain is not well managed. Yeah. It can be unbearable at times. And when you carry that cross for years and years, that can be that irremediable suffering. And we talked again off camera about this. This is a great fear of mine as a pain consultant, that people are going to look at things like physician assisted death as a way to deal with chronic pain at times, which I think would be sad. Particularly again, when people hear, particularly when they come to me, people come to me in my pain practice as kind of the mecca here. I'm going to go and see Dr. Hauptman. He's a pain consultant. He works in a tertiary care pain clinic. He's going to take all my pain away. And when I tell them I'm not, that's a real blow. You're going to have chronic pain for the rest of your life. And a lot of my patients break down when I tell them that. I'm going to work with you. We're going to work together. We're going to help your suffering. But I'm sorry, I can't cure your chronic pain.
So when we say that all pain can be managed, that doesn't mean that you can get rid of it or cure of it.
And that at that point is where a lot of people can initially, I think, lose it and feel like, what's the point? Why should I go on? And the way the Supreme Court of Canada decision is, at that point, particularly if there's no cooling off period, which we now know this is being debated, whether there should be one, theoretically somebody could come up to me and say, hey, Dr. Hauptman, I can't live with this. If you do not have a cure for me, I want you to end my life.
Okay, I want to hold on to that because I want to ask you about that. But first, it's a quality of life issue. Would you say that it's a quality of life issue? I don't. From what I know of you, I would say that you would say that you have a good quality of life.
Right.
Can it? Is it that patients say, well, there's no point in living because there's no quality in this life?
Fair enough. I think the point I was trying to make, Deacon, to go back, if you would have asked Lisa the same question when she first met me. So when that patient comes in to see you for the first time, and they're coming in with the expectation that you're going to cure them, and you as a pain consultant say, I am not going to cure you. You will have chronic pain for the rest of your life. That can be a real hard message. But the good news I think you're pointing to is I think that that's not what they have to live with. I think, Lisa's a great example. She's one of my heroes as far as I'm concerned, of somebody who has taken the message of what you can do to change your life, and faced with a lot of adversity, she's been able to move forward and show, hey, you can live with chronic pain, you can have a good quality of life. But to get to that, it took us.
It took a long time.
Yeah, exactly.
It was a blow when I realized that I couldn't just take a pill and have the pain go away. Like Dr. Hauptman said, I was expecting that to happen. And so it took a while, like I would say probably a good 6 months before I realized that I needed to do some work as well to manage the pain.
Yeah.
And some of my fear, of course, is in that fragile period of time when things seem a bit hopeless, where they hear some of this messaging, is again, if there is a, somewhat of a push here, well, why don't I just end it?
Right.
Because you know what, I can now. I'm competent. I have an irremediable disease. It causes suffering. It's not curable. And the Supreme Court of Canada says I can.
Yes. And I would, again, my point that I made earlier that I guess it didn't really go anywhere about age, if you were dealing with a patient who is 80 years old, that they're closer to, well, I've already lived my life, what's the point? I'm closer to dying anyway. Why not end it all? Have you had patients, I mean, I suppose you have patients telling you, can you end it all?
Yeah.
But have you had patients ask you for that?
Absolutely. Oddly enough, it's often the younger population.
Really?
And maybe, to be fair, they see it because here I am in the middle of the most productive years of my life, and I can't support my family. I can't be a good wife or a husband. And they see it more devastating. Oddly enough, somebody who's 80, they want to work with me. They are more than happy a lot of times. I don't get as much requests with people coming in saying, I just want to end it all at an 80-year-old patient as I do with a 40-year-old patient.
Do you feel that once the law changes that there's going to be more pressure on you to go against your own beliefs and conscience to refer people or to, well, I guess you wouldn't do it, but to refer them?
Yeah, I think that is a real potential fear. There's a lot of discussion around these end-of-life things and even the protections that they theoretically want to prove in, which because they don't think are good safeguards. They're saying, no, we shouldn't have a cooling off period. It doesn't matter what age you are. You may have heard this discussion now that, they're saying that why are we arbitrarily saying 18-year-olds? Why not 14-year-olds? And these types of things. I personally, though, and I've been very strong about this, and I've made it publicly clear that I will never refer for physician-assisted death, even if for some reason my professional body says that I will have to. I will not. Even that is just too much against my own personal conscience. Not only as a person of faith, and I do have a strong faith, as you know, but I believe that there's medical issues here. My profession has always been a profession that's upheld life and has been there to ease pain and suffering. Ending life is not easing pain and suffering. And ending someone's life is not a treatment. I mean, think of any medical textbook. They don't say, hey, if you have bad COPD, you do, which is emphysema, pardon me, do this, and if that doesn't work, you can end their life as a treatment option.
Yeah.
It's really interesting. And one of the things that's often left out of this discussion of end-of-life discussions is the fact that this was kind of put on the medical profession when none of us really asked for it.
No.
The court said, hey, yeah, patients have a right, but why should physicians be the ones doing this? I think this is a real problem.
How would your relationship with your doctor change if this was on the table? Would you feel less comfortable going to the doctor for help?
It's an interesting question.
That is an interesting question.
But I know that it's a fear. People have already expressed that fear. But here I have a patient and her doctor.
Right. That's not something that I would be asking for.
No.
I have a great deal of faith as well, and
I guess the question is, how hard would Lisa work, or how hard would I work to get her better if that's an end stage option.
Yes.
You know, some of my pain patients have taken me 2 to 3 years to get them better. Lots of sweat, lots of tears, even Lisa's journey.
Yeah.
And if, you know, and maybe I say at some point, you know what, you know, I've tried for 3 months, heck, it's not working, I'm not gonna try anything else. Let's just offer, you know, Lisa, you're suffering, let's just end it. You know, you're burning on your family, you're burning on my
that's
practice.
the fear, of course. Yeah.
You know, you're always phoning and complaining. That's just, you know. So I think there is a point there. You know, when that's not an option, I'm going to do everything in my power as a physician to help my patients in their journey.
Of course.
It's never going to be an option for me.
We're very close to the end of our time, but I want to not leave without maybe letting you, for people who are out there who maybe are watching, who are suffering, who are maybe suffering alone. You have a family and support and a great doctor. Not everybody has that. What would you like to tell them, Lisa?
That they're not alone. You know, for the first 6 months after I started seeing Dr. Hauptman, it was a rough go, and I had a tendency to kind of shut out family members. But then I decided the more people that are aware of my situation, the more support I could have, and that it does get better if I found if I have a positive outlook and I make that choice every morning to, you know, be happy, but besides the pain, that, you know, others can do that as well.
And we're very glad that you do every morning make that choice. And thank you for sharing your story with us.
Thank you.
Yeah. Thank you for your expertise and for the work that you do.
Super, thanks for having me.
Lisa Daniels chooses to be happy despite, you know, some trying circumstances. And Dr. Robert Hauptman, who is a family physician and pain consultant, and he helps people like Lisa. Thank you so much for being with us. If you have any questions about anything you heard on this program or anything that you hear on this on Catholic Focus, you can always send us an email, focus@saltandlighttv.org. You can also reach us through Facebook and Twitter. That's all for tonight. May God continue to bless you and your home.